Hi again. So I'm here to read section 8 of the pocket guide for lactation management. I have been off my game for several days, probably because I've been putting off reading section 8 because it's a lot. And I knew that I would have to be really disciplined and sit and read through this whole thing. But that is the reason why I'm recording this series, so that I can be disciplined and get through the entire book. So I'm here. It's the morning. I'm here with my coffee. I got up a little bit late because I wanted to prioritize rest today. But other than that, I'm going to get right into it. So, Section 8, Baby Feeding Problems. Concern: my baby won't latch on. Descriptor: baby will not feed when offered the breast. Feeding refusal indicates that something is amiss, and it is normal for the baby to express desire and suckle, even if not hungry. Feeding refusal can be continuous, one sided, sporadic. Unique identifier: feeding refusal that is continuous. The baby refuses to feed from the breast. Generally, this refers to the baby who will not latch to the breast, although sometimes babies latch and then immediately pull off, usually crying. Ask yourself: have the baby's weight gain and output been appropriate? Appendices H and I. Does the baby look dehydrated, jaundiced, or otherwise malnourished? Does the baby seem alert and active or lethargic? Are the breasts so full and hard that the baby is unable to form a teat? Has the baby been forced to the breast with pressure on the back of the head? What is the family's response to the baby's refusal? If the onset is sudden and refusal is continuous, what has changed recently? For example, has the thicker for example, has the thicker newborn milk increased in volume? Has there been a change in the family routine? Is the nursing parent taking any new medication, nutrition supplement, herbs, etc.? Watch out for presence of feeding cues prior to feeding. Process used to bring the baby to the breast. Visible signs of pain for either member of the dyad. What to do about it? If the breasts are hard and full, sufficient softening should be done before attempting another feeding. See engorgement section for softening techniques. If aggressive latch techniques have been used or there has been pressure on the back of the baby's head, skin to skin contact and allowing the baby to self attach has been shown to be an effective resolution strategy. If the baby seems to have trouble dealing with increased volume or milk flow, be sure the baby is not in a dependent position. Be sure there is the possibility for the baby to move the head away from the breast and let the milk spray. Observe a feeding using the feeding observation checklist, Appendix B. If the baby refuses to latch, ask that the baby be held skin to skin until feeding cues are observed and the baby moves toward the breast. Encourage bringing the baby close to the breast immediately upon observation of feeding cues, but allow the baby to feed the breast and self-attach. Remember that babies need to familiarize before latching as they learn the sounds and smells and tastes of feeding at the breast. Suggest alternate positions. Encourage the use of hand expression to release a few drops of milk to offer the baby to smell and lap. If the baby latches, use alternate massage breast compression to increase flow if the baby becomes fidgety. Suggest other changes to feeding process indicated by the feeding observation. Persist in trying to uncover the underlying reason for difficulty in coming to the breast. Babies should show desire. Not doing so raises concern. Continuing demonstration of a lack of desire warrants a comprehensive pediatric exam. Schedule follow-up and ensure appropriate referrals. Expected resolution. Comfortable and effective feeding postures and positions, Appendix C, will be found. If the baby cannot be helped to breastfeed and the pediatric care provider has prescribed supplementation, Appendices E, F, and G, frequent skin-to-skin care is encouraged in order to assist the baby in developing comfort when being held to the breast. Consider at-breast supplementation if supplementation is prescribed. Work to ensure adequate milk expression in order to build and/or maintain an abundant milk supply. And I'm just going to stop here because there is an image here. Figure 8.1, alternate massage of or breast compression is a way to increase the flow of milk to the baby. The breast is compressed when the baby pauses. And so there she's pressing the breast. Okay, let me go back to the reading. What else to consider? What else to consider? If observation and positioning guidance do not resolve refusal, referral for immediate broader evaluation is required. Problems such as stuffy nose and other respiratory problems, ear or other infection, and trauma such as fractured clavicle or torticollis must be ruled out. Babies with neuromuscular problems, those who have experienced painful procedures to the head, for example, suctioning, intubation, or repeated examination, and those who have been forced to the breast may refuse to feed. The pediatric care provider may recommend supplementation. In the case that supplementation has been ordered, suggest maintaining or building the milk supply, Appendix J, through milk expression. Also consider use of an at-breast supplementer, and that's in Appendix N. Consider the family situation as well. If the milk supply is low or the flow from the breast is slow, the baby who has been exposed to the bottle nipple may refuse the breast. In this case, fine-tuning the latch and positioning and using alternate breast massage or breast compression, Figure 8.1 and Appendix D, or an at-breast supplementer, Appendix N, may assist in keeping the baby at the breast. Both members of the dyad should be examined by their health care provider. Breast refusal may indicate that there is an abnormal process occurring in the breast or body, e.g. cancer, Goldsmith's sign, or lupus. This is rare, but should always be a considered possibility if other reasons for breast refusal are not found. Feeding refusal, in our opinion, feeding refusal must be taken seriously. Babies can dehydrate very, very quickly. It is best to err on the side of caution in these cases, particularly when the baby is a newborn. Sometimes family or friends will advise that the baby should be allowed to become hungry, suggesting that when the baby is hungry enough, he or she will accept the breast. This is a dangerous strategy that may be detrimental to the baby's health. Occasionally, feeding refusal is caused by a misunderstanding of when to feed the baby. Perhaps the baby is being held to a schedule rather than being fed when showing early feeding cues, or the baby is expected to cry as a hunger signal before being fed. Sometimes the family is concerned that responding to feeding cues will spoil the baby. We do not believe it is possible to spoil a baby by responsive caregiving. Concern: my baby won't latch on. Descriptor: baby will not feed when offered the breast. Feeding refusal indicates that something is amiss, and it is normal for the baby to desire to suckle, even if not hungry. Feeding refusal can be continuous, one-sided, sporadic. Unique identifier: baby refuses one breast but not the other. Ask yourself, have the baby's weight gain and output been appropriate? Is there something different about how the baby is held on one breast versus the other? Is one breast or nipple substantially different from the other? What is the baby's body language when positioned on the breast? Watch out for consistency of one-sided refusal. Does the baby always refuse the same breast, left or right? Or is the baby refusing different breasts at different feeds? For example, the baby finishes the first breast and refuses the second because one side is sufficient at this time. What to do about it? Observe a feeding using the feeding observation checklist, Appendix B. If the baby consistently refuses the same breast, suggest offering the baby the preferred breast. When the baby releases that breast, move the baby to the other breast without shifting the baby's body position, as in Figure 8.2. For example, consider baby Fred, who will nurse happily on the right breast but always refuses the left. If Fred is nursing on the right breast in cradle position, suggest sliding him over to the left so that he is now approaching the left breast from the football position. If Fred will accept the left breast when held in the position accepted on the preferred breast, it may indicate some kind of physical discomfort associated with lying on the other side of his body, e.g., ear infection, fractures, strains, Erb's palsy. In this case, Fred needs pediatric evaluation. If the position switch does not result in latching onto the less favored breast, then suggest trying other positions. If unable to assist the baby in latching, refer both for medical evaluations. Rarely, breast refusal has indicated abnormal process in the breast or parent's body, e.g., cancer, lupus, or in the baby's body, e.g., head or brachial plexus injury or torticollis. If the baby prefers only one breast per feeding but does not always refuse the same breast, collect a pre-feeding weight if possible. Listen for sounds of swallowing, rhythm of sucks to swallows, and any milk escaping from baby's mouth during feeding. In this case, it is possible that the baby is receiving adequate milk at one breast and cannot handle the volume from both breasts during a feed. This is normal and reflects an adequate or even abundant milk supply. Inquire if there is any discomfort associated with overfullness on the unsuckled breast. If so, suggest hand expression to ease the fullness without removing much milk, which would cause an even greater milk supply. Conduct a post-feeding weight check. Calculate milk transfer. Calculate the baby's appropriate daily needs, Appendix F, and divide that figure by the number of reported feeds in 24 hours. How does the amount arrived at compare with the amount of milk transferred during this feeding? If the transfer estimate is much lower than the estimated need, follow the protocol for poor milk supply and milk transfer. If the transfer estimate is higher than the estimated need, follow the protocol for oversupply. If the transfer estimate is roughly the same as the estimated need, schedule follow-up contact to ensure that the problem is resolving. Note, any single feeding does not necessarily indicate a typical milk intake. For this reason, it is helpful to observe several feedings over a period of time to get a better estimate of average transfer. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and ensure appropriate referrals. Expected resolution. If the resolution for one-sided refusal is identified, the problem should resolve quickly. In many cases, an adequate milk supply is possible even if the baby only suckles on one breast. However, milk expression for comfort or to build the supply may be needed should supplementation be prescribed. What else to consider? Other medical problems for either member of the dyad. In our opinion, differences in the rate of milk flow may describe the majority of one-sided feeding or breast preference that is not restricted to the same breast at each feed. However, we must be vigilant for those cases that do not fall into this category, particularly the case where the breast refuse is always the same side. Pre- and post-feeding weight checks are a useful tool that can be overused. They should be used only when there is a genuine need to evaluate milk supply or, as in the case of this presenting problem. Overuse may be disempowering and suggest that the focus should be on the quantity of milk rather than the quality of feedings. Concern: my baby won't latch on. Descriptor: baby will not feed when offered the breast. Feeding refusal indicates that something is amiss and it is normal for the baby to desire to suckle, even if not hungry. Feeding refusal can be continuous, one-sided, or sporadic. Unique identifier: baby sporadically refuses to feed. Ask yourself, have the baby's weight, gain, and output been appropriate? What factors are associated with this baby's refusal? Is the refusal associated with a change in milk flow, as when volume increases during the early weeks or during the feeding when the milk flow increases? Is the refusal associated with times that the breasts are harder, fuller, and the baby struggles with forming a teat? What is different about those feedings in which the baby refuses the breast? Watch out for body language of each member of the dyad. What to do about it? Ask about conditions under which the baby has refused the breast, such as time of day, portion of feed during which refusal is seen, e.g. at the beginning or end of the feed, when milk flow slows or increases. The baby's hunger level, how decisions are made about when to feed, presence of external stressors, e.g., noise level, activity in household before or after separation from the baby, and use of bottles, pacifiers, or medications for each member of the dyad. Probe for anything that is different about the days and times that the baby refuses to feed. Observe a feeding using the feeding observation checklist. If the baby refuses to latch during observation, ask for the baby to be held skin to skin until feeding cues are observed. Encourage bringing the baby to the breast when feeding cues are observed. Suggest trying alternate positions. Trying alternate positions. Encourage using hand expression to release a few drops of milk to offer the baby to smell and lap. If the baby latches, use alternate massage, breast compression to increase flow if the baby becomes fidgety. If the problem seems to be that the baby pulls away when the milk flow increases, try a less dependent, more upright position. Be sure the head is not being held and that there is no pressure against the back of the head. If position changes do not resolve the inability to cope with changes in flow, a swallow study may be warranted. Let me read that again. If position changes do not resolve the inability to cope with changes in flow, a swallow study may be warranted. If observation and positioning guidance do not resolve refusal, a comprehensive pediatric evaluation is indicated. Medical problems, e.g., stuffy nose, infection, trauma, must be ruled out. The pediatric care provider may recommend supplementation. In this case, work to maintain or build the milk supply through milk expression. Appendices J and M. Use the expressed breast milk preferentially to formula and consider use of an at-breast supplementer. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and ensure appropriate referrals. Expected resolution. When reasons for sporadic feeding refusal are identified and addressed, the problem should gradually resolve. The nursing dyad learns how to accommodate one another gradually over the early weeks of breastfeeding. What else to consider? Might the baby be in pain when held in certain positions? A comprehensive pediatric evaluation of the baby is indicated. Babies with birth trauma, torticollis, ear infection, teething pain, and so on may refuse feeding. Babies with neuromuscular conditions, those who have experienced painful procedures to the head, e.g. suctioning, intubation, repeated examination, and those who have been forced to the breast may refuse to feed. If supplementation is prescribed, use expressed milk preferentially. Encourage skin-to-skin care as much as possible to assist the baby in developing comfort being held to the breast. Consider at-breast supplementation in this case. Assist in ensuring that expression is adequate to maintain an abundant milk supply. Ask the nursing parent if any of the following are occurring. Menstruation. Some report that babies refuse their milk or fuss at the breast during the premenstrual and menstrual periods. Fuller, harder breasts. Change from lower volume newborn milk to higher volume mature milk in the early days postpartum. Baby response to milk volume increase during letdown. New use of perfume lotion, soap, detergent, or other aromatic substances. The baby may be reacting to these new scents. Pause. So one thing that I do discourage when I'm at a birth, I do use lots of essential oils, but I try to refrain from the essential oils when the baby is born and try to have things a little bit fresher or closer to the mom scent so that the baby is not deterred from, the baby gets to know mom and becomes familiar with the breast, and it aids breastfeeding. So just consider that if you're using essential oils during a birth. Starting or sporadically taking any new or strongly flavored medication, herbs, and or nutritional supplement. The baby may be reacting to these new flavors. In our opinion, sporadic feeding refusal typically denotes some miscoordination between nurser and nursling. Observing and suggesting appropriate responses to the baby's cues is often all that is needed to help overcome this problem. Concern: my baby latches on but doesn't stay attached, doesn't sustain the feeding. Descriptor: difficulty keeping baby attached to the breast. This concern indicates a need for feeding observation as the baby is unable to maintain an adequate seal at the breast, resulting in ineffective milk transfer. Unique identifier. Baby latches to the breast but does not maintain a seal. Ask yourself, have the baby's weight gain and output been appropriate? Does the baby appear well nourished? Does the baby seem appropriately interactive and interested in feeding? Watch out for lips not sufficiently flanged out or lips rolled in. Mouth not open wide enough, 140 to 160 degrees, to take in sufficient breast tissue. Potential anomalies of the baby's mouth or of the breast and or nipples. So sometimes the babies that have the lip surgery, they may have challenges. Um, Location of parents' hands during feeding and the baby's body language. What to do about it? Attain a pre-feeding weight if possible. See protocol in Appendix E. Watch closely for the baby's interest in feeding. If feeding attempts happen when the baby is not indicating feeding readiness, reteach feeding cues and appropriate responses. If the baby is not in a receptive state, encourage skin-to-skin contact until feeding cues are seen. Observe a feeding using the feeding observation checklist. Note the condition of the latch before the baby latches off of the breast. Was the baby nursing well and then became overwhelmed by a change in milk flow? When the baby is attached to the breast and does not maintain seal, suggest detaching the baby and using hand expression to release a few drops of milk for the baby to smell and lap. Observe the baby attempting to latch again. Suggest different positions. Conduct a post-feeding weight check. Calculate milk transfer. Calculate the baby's approximate daily needs and divide that figure by the number of reported feeds in 24 hours. How does the amount arrived at compare with the amount of milk transfer during this feeding? If the transfer estimate is much lower than the estimated need, follow the protocol for poor milk supply and transfer. If the transfer estimate is higher than the estimated need, consider the protocol for oversupply. If the transfer estimate is roughly the same as the estimated need, schedule follow-up contact to ensure that the problem is resolving. Note, any single feeding does not necessarily indicate a typical milk intake. For this reason, it is helpful to observe several feedings over a period of time to get a better estimate of average transfer. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and ensure appropriate referrals. Expected resolution. When reasons for attachment difficulties are identified and addressed, the problem should gradually resolve. Nursing dyads learn how to accommodate each other gradually over the early weeks of breastfeeding. What else to consider? If observation and positioning guidance do not resolve the problem, refer the baby to the pediatric care provider for evaluation. Problems such as stuffy nose, respiratory issues, tongue tie, clefts of the hard or soft palate. Yes, that's what I meant before, cleft palate. And neuromuscular or cardiac issues must be ruled out. The pediatric care provider may recommend supplementation. In this case, suggest ways to maintain or build the milk supply through milk expression and encourage skin-to-skin care as much as possible to assist the baby in developing comfort being held to the breast. In our opinion, babies who do not maintain a seal are telling us one of several things. Either they cannot maintain a seal due to issues such as undernourishment, attachment problem, or intraoral structure or neuromuscular problem, or they do not want to maintain its seal, perhaps because the rate of milk flow is too fast or because of discomfort associated with feeding. Concern. My baby is not comfortable at the breast. Descriptor. Baby expresses distress related to feeding. Let me have a cup of coffee. Babies may express discomfort at the breast in many ways. These can include fretting at the breast, crying at the breast. Unique identifier. This baby is expressing distress during feedings through sounds and body language. This behavior may be described as fussing or fretting at the breast, or as the baby not wanting to stay at the breast. The physical behaviors of the baby may include pushing away from the breast, batting at the breast, and so on. Ask yourself, Is the baby exhibiting expected familiarization behaviors that are being interpreted as discomfort? For example, the newborn often attaches several times with a small degree of mouth opening before settling into a deeper latch with rhythmic suckling. Have the baby's weight gain and output been appropriate? Does the family demonstrate an understanding of the baby's feeding cues and respond appropriately? Could the baby be having difficulty breathing? Could the baby be having trouble coordinating sucking, swallowing, and breathing? Could either member of the dyad be in pain? Watch out for changes in the baby's body position or the way the baby is supported during feeding. Changes in the baby's lip and facial skin color during a feeding, e.g., becoming pale, gray, dusky, or blue. These changes may indicate an undiagnosed physical problem for the baby. Comprehensive pediatric evaluation is urgently required before attempting another oral feeding. Fretting or pulling away that appears to be necessary for the baby to breathe. In these cases, consider a swallowing, coordination, or respiratory problem. Comprehensive pediatric evaluation is urgently required before attempting another oral feeding. What to do about it? Observe a feeding using the feeding observation checklist. Watch closely for the baby's interest in feeding. If the baby is not indicating feeding readiness, reteach feeding cues and appropriate responses. If the baby is not in a receptive state, encourage skin-to-skin contact, allowing the baby to self-attach or begin collaborative feeding when feeding cues are seen. When attached to the breast, if the baby begins to fret, encourage moving the baby into skin-to-skin position until feeding cues are seen again. Then watch the process closely to see if there is a difference in positions before and after the fretting begins. If fretting continues, try different positions. Suggest the use of alternate massage, breast compression to change the rate of flow of the milk. Observe for sucking and swallowing. Does the baby begin to fret when the milk is flowing rapidly or slowly? Listen to the suck to swallow ratio to answer this question. Nutritive flow is thought to occur at 1 or 2 sucks per swallow. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and or ensure appropriate referrals. Expected resolution. The behavior should resolve when the problem is identified and appropriately addressed. If the change requires a new way of holding the baby, it may take some time for the dyad to finesse the new position. Encourage a follow-up observation to fine-tune the positioning. What else to consider? If the problem cannot be resolved, the baby requires a comprehensive pediatric evaluation. In some cases, stuffy nose as well as more serious problems such as submucosal clefts and other anomalies have been associated with this behavior. Hungry babies often exhibit this fretting and batting the breast behavior. This can be misread as anger. However, it may also reflect the baby's needing behavior at the breast, which has been associated with increased oxytocin and thus enhanced milk flow. Similarly, the baby's pulling away may be the baby pushing back against something that is restricting his or her ability to get the widest mouth opening, which the breastfed baby comes to associate with the greatest milk flow rate. One of the most helpful acts of supportive lactation care provider may be interpreting the baby's body language correctly to the family. Concern. My baby is not comfortable at the breast. Descriptor. Baby expresses distress related to feeding. Babies may express discomfort at the breast in many ways. These can include fretting at the breast, crying at the breast. I'm just going to pause here because we have about 40 pages left. I need to take a break because my face has been dry and my hands have been dry. Just give me 1 second. I just need to moisturize because I feel so dry. Okay. 40 pages left. I can do this. I can do this. I can do this. Focus. Cup of coffee. Oh, cup of water. Let's go. Unique identifier. The baby is expressing distress during the feeding by pulling away and crying. This may happen before or during feeding. Ask yourself, Have the baby's weight gain and output been appropriate? Could the baby be in pain? Are the baby's feeding cues being misread? Are feedings being delayed? Watch out for whether or not there is an appropriate response to feeding cues, position of the dyad before and after the crying starts. Oh, I'm sorry, let me read that again. Watch out for bullet 1, whether or not there is an appropriate response to feeding cues. Bullet 2, position of the dyad before and after the crying starts. What to do about it. Observe a feeding using the feeding observation checklist. Watch closely for the baby's interest in feeding. If attempting a feed when the baby is not indicating feeding readiness, reteach feeding cues and appropriate responses. If the baby is not in a receptive state, encourage skin-to-skin contact, allowing the baby to self-attach or begin collaborative feeding when feeding cues are seen. When attached to the breast, if the baby begins to cry, encourage moving the baby into skin-to-skin position until feeding cues are seen again. Then watch the process closely to see if there is a difference in positions before and after the fretting begins. Look for restriction of the baby's head, position of the baby's arms and legs, and so on. If crying continues, try different positions. Suggest using alternate massage breast compression to change the rate of flow of the milk. Observe for sucking and swallowing. Does the baby begin to cry when the milk is flowing rapidly or when it is not flowing? When the baby pulls away, is there a spray of milk? If so, perhaps the flow of milk is too strong and the baby is dealing with a change in flow by pulling away and crying. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and ensure appropriate referrals. Expected resolution. The behavior should resolve when the problem is identified and appropriately addressed. If the change requires a different way of holding the baby, it may take some time for the dyad to finesse the new position. Encourage a return for follow-up observation to fine-tune the positioning. What else to consider? If the problem cannot be resolved, a comprehensive pediatric evaluation is indicated. Problems such as stuffy nose, teething pain, injuries such as fractured clavicle or brachial plexus injury, and other anomalies have been associated with this behavior. In our opinion, it is unfortunate that many caregivers equate crying with hunger and soothing with spoiling. The baby who is crying is telling us that something is wrong, and responsive attention is needed to discern and respond to the baby's needs. Concern. I'm worried about my milk supply. Descriptor. Concern about adequacy of milk supply. Often parents are concerned about producing an adequate amount of milk. So there's a chart here. I'm going to read the chart after I read this section. So, I'm worried about my milk supply, concerned about adequacy of milk supply. Often parents are concerned about producing an adequate amount of milk. Friends and family may support this concern. Among the factors that may increase this concern are the following. Baby has not gained an adequate amount of weight. Baby falls asleep after just a few minutes of feeding. Baby seems unsatisfied after feeding. After feedings, breasts feel empty. Expressed milk volume is less than expected. Baby wants to feed more often than expected. So let me go back. This chart lists like the pages that you're supposed to jump to for specific questions. So the overall question is, I'm worried about my milk supply. The first box, baby has not gained an adequate amount of weight. It tells us to go to page 18. Baby falls asleep after just a few minutes of feeding, page 121. Baby seems unsatisfied after feedings, page 124. Breasts feel empty, page 127. Expressed milk volume is less than expected, page 129. Baby wants to feed more often than expected, page 132. So this goes to show, even though I'm reading this to you and you may be going about your day, and listening to the book is very helpful, you do still need the book, and this is going to be a great reference guide for you. You also will need this book if you are taking the exam. There are certain questions that you're going to be asked during the competencies, and you need to have the book on hand. So just a reminder. So going back to the reading, a unique identifier. poor weight gain in the baby is reported. The baby's weight gain is thought to be problematic or has been measured and found inadequate. Ask yourself, has the baby's pediatric care provider identified a problem with the baby's weight gain pattern? Has the baby's output, especially stools, been appropriate? Does the baby appear dehydrated or jaundiced, malnourished? Is the baby's behavior appropriately interactive? Does the family report that the nighttime feedings seem to go better than the daytime feedings? Watch out for parental knowledge of and response to the baby's cues. Description of daytime demands and routines that lower the priority to breastfeed at the baby's best time. When the nighttime feedings are better, it may be because the baby is close by and cues are more likely to be noticed. Possibility of inaccuracy of measurements, e.g. weights taken on different or inaccurate scales. Use of an inappropriate growth chart to track the growth of exclusively breastfed babies, especially after 4 to 6 months. The WHO growth curve should be used for all babies under 24 months. What to do about it? Obtaining a breastfeeding weight if possible. See protocol in Appendix E. Observe a feeding using the feeding observation checklist. Observe the baby's approach to the breast. Does the baby exhibit interest in feeding? Does the baby seem to be conserving energy, or is he or she actively feeding? When the baby is attached to the breast, observe for sucking and swallowing. The suck to swallow ratio should be at or below 4 to 1 with intermittent bursts of 1 to 1 and 2 to 1. This is the pattern of nutritive feeding at the breast. Suck to swallow patterns of above 4 to 1, especially without 1 to 1 or 2 to 1 bursts, indicate that milk is transferring at a rate that is too slow to be considered nutritive. If the baby stops suckling and appears to go to sleep, suggest alternate massage or breast compression to increase the rate of flow of the milk. Observe the sucking and swallowing after compression. Does the baby get more wakeful and suckle more actively, or does the baby break suction, indicating a problem in managing the flow? Conduct a post-feeding weight check. Calculate milk transfer. Calculate the baby's approximate daily needs. Actually, let me just pause for a second, because now that I'm reading this, so it's really important. This is why it's so important to observe. You have to really observe, because a sleepy baby at the breast is not necessarily a contented baby. The baby, it could be that they're not having a good suck to swallow ratio. This is why it's so important to observe. When you're watching the class and you're watching the videos of the baby sucking and swallowing, it's really important to do that when you're with your families, to really take the time to observe a feeding, and then you can see if the suck and swallow is not the ratio that would encourage more milk flow. Okay, conduct a post-feeding weight check. Calculate milk transfer. Calculate the baby's approximate daily needs and divide that figure by the amount of reported feeds in 24 hours. How does the amount arrived at compare with the amount of milk transferred during this feeding? If the transfer estimate is much lower than the estimated need, follow the protocol for poor milk supply or transfer, Appendices J and L. The pediatric care provider should determine the need for supplementation. Note, any one feeding does not necessarily indicate a typical milk intake. For this reason, it is helpful to observe several feedings over a period of time to get a better estimate of average transfer. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and ensure appropriate referrals. Expected resolution. When inadequate weight gain is confirmed, intensive pediatric follow-up and breastfeeding assessment, corrective intervention, and education are indicated. In most cases, milk supply can be increased and milk transfer can be improved. If a milk supply and or transfer problem is not confirmed, additional follow-up is indicated to ensure appropriate growth. What else to consider? The pediatric care provider may prescribe supplementation. In this case, suggest ways to maintain or build the milk supply through milk expression. Use express milk preferentially as a supplement. I need to write a note. Where's my pen? Always when I need to write a note, I can't find a pen. And I have so many pens. It's frustrating. Here's a pen. And of course, I dropped the cap of my pen, so sometimes you just gotta write that note as it comes. Okay. Where was I? What else to consider? The pediatric care provider may prescribe supplementation. In this case, suggest ways to maintain or build the milk supply through milk expression. Use expressed milk preferentially as a supplement and consider use of an at-breast supplementer to deliver supplement or expressed milk. If a milk supply transfer problem is confirmed but not explained by pediatric evaluation, a comprehensive maternal medical evaluation is indicated. Occasionally, medical issues such as endocrine insufficiency, polycystic ovarian syndrome, medications, superimposed pregnancy, and other conditions have been associated with milk production that is less than adequate. In our opinion, it is essential to explore this concern fully. Too many times the advice is given to stop worrying about the milk supply or to just go to bed and nurse the baby to increase the milk supply. Any concern about milk supply deserves our full exploration and examination. No matter how common a concern this is, we have no way of knowing when we are dealing with a situation that is far from either common or normal. There is a traditional saying that parents know when something is wrong. Strive to honor their knowledge by fully exploring their concerns, no matter how common. Concern. I'm worried about my milk supply. Often concerned about adequacy of milk supply. Often parents are concerned about producing an adequate amount of milk. Hold on, let me check this. What was the last section? This is a repeat. Just now reading. Is it a repeat? Have the parents gained? Has the baby? Sorry, I just want to make sure that this is not repeated. The baby falls asleep. Okay. It's very similar. I don't like that. It's very similar. It makes you seem like you're reading the same thing over and over. Concern, I'm worried about my milk supply. Descriptor, concern about adequacy of milk supply. Often parents are concerned about producing an adequate amount of milk. Friends and family may support this concern. Among the factors that may increase this concern are the following. Baby has not gained an adequate amount of weight. Baby falls asleep after just a few minutes of feeding. Baby seems unsatisfied after feedings. Breasts feel empty. Expressed milk volume is less than expected. Baby wants to feed more often than expected. The baby falls asleep after just a few minutes of feeding. The baby may have just been told that feeding the family may have been told that feeding the baby will take a certain amount of time. This can lead to concerns about milk supply when their baby nurses for a shorter time and then falls asleep. So this is a reason probably why you should not say nurse for 15 to 20 minutes. Like, people are so focused on that time, the baby nursing in that time, and it's really about the quality of the feeding. Ask yourself, have the baby's weight gain and output been appropriate? Does the baby appear dehydrated, jaundiced, malnourished? Is the baby's behavior appropriately interactive? Watch out for the family's knowledge of and response to the baby's cues. Misreading of quiet alert stage with eyes closed as sleeping. Active feeding can occur during baby states that look inactive to adult observers. What to do about it? Obtain a pre-feeding weight if possible. Observe a feeding using the feeding observation checklist. Watch closely for the baby's interest in feeding. If the feeding is attempted when the baby is not indicating feeding readiness, re-teach feeding cues and appropriate responses. If the baby is not in a receptive stage, encourage skin-to-skin contact until feeding cues are seen. When the baby is attached to the breast, observe for sucking and swallowing. If the baby stops suckling and appears to go to sleep, suggest alternate massage. To change the rate of if the baby stops suckling and appears to go to sleep, suggest alternate massage to change the rate of flow of the milk. Observe suckling and swallowing. Does the baby get more wakeful and suckle more actively, or does the baby break suction? Conduct, conduct a post-feeding weight check. Calculate milk transfer. Calculate the baby's approximate daily needs and divide that figure by the number of reported feeds in 24 hours. How does the amount arrived at compare with the amount of milk transferred during this feeding? If the transfer estimate is much lower than the estimated need, follow the protocol for poor milk supply. If the transfer estimate is higher than the estimated need, follow the protocol for oversupply. If the transfer estimate is roughly the same as the estimated need, schedule follow-up contact to ensure that the problem is resolving. Note: any one feeding does not necessarily indicate a typical milk intake. For this reason, it is helpful to observe several feedings over a period of time to get a better estimate of average transfer. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and ensure appropriate referrals. Expected resolution. When the reasons for sleepiness are identified and addressed, the problem should gradually resolve. The dyad learns how to accommodate one another gradually over the early weeks of breastfeeding. What else to consider? If the baby is a newborn, consider near-term or prematurity, labor, analgesia, anesthesia, infection, and hyperglycemia as possible contributing factors. Ensure comprehensive pediatric evaluation. In our opinion, there is no right amount of time for a feeding to last. However, concerns about feedings that are too short or too long also warrant a feeding evaluation. Although most newborn babies have longer feeds as they learn how to feed effectively, experienced babies may be able to transfer significant volumes of milk in a very short amount of time, as little as 5 minutes in some cases. Supply. Concern. I'm worried about my milk supply. Again, this is going to sound very similar to what I just read, which is frustrating, but it's a different section. Descriptor. Concern about adequacy of milk supply. Often parents are concerned about producing an adequate amount of milk. Friends and family may support this concern. Among the factors that may increase this concern are the following. Baby has not gained an adequate amount of milk. Baby falls asleep after just a few minutes of feeding. Baby seems unsatisfied after feedings. Breasts feel empty. Expressed milk volume is less than expected. Baby wants to feed more often than expected. Unique identifier. After breastfeeding, the baby is unsettled and fretful. Ask yourself, have the baby's weight gain and output been appropriate? Does the baby appear dehydrated, jaundiced, malnourished? Is the baby's behavior appropriately interactive? Does the baby only get attention and skin contact during feedings? Watch out for family's knowledge of and response to the baby's cues. Obtain a pre-feeding weight if possible. See protocol in Appendix E. Observe a feeding using the feeding observation checklist. Watch closely for the baby's interest in feeding. If feeding is attempted when the baby is not indicating feeding readiness, reteach feeding cues and appropriate responses. If the baby is not in a receptive state, encourage skin-to-skin contact, allowing the baby to self-attach or begin collaborative feeding when feeding cues are seen. When the baby is attached to the breast, observe for sucking and swallowing ratios to confirm that the feeding is nutritive. Ratios of suck to swallow of 4. This is my cat, Son. Say hi, Son. Hi. Conduct a post-feeding weight check. Calculate milk transfer. Calculate the baby's approximate daily needs. Calculate the baby's approximate daily needs and divide that figure by the amount of reported feeds in 24 hours. How does the amount arrived at compare with the amount of milk transferred during this feeding? If the transfer estimate is much lower than the estimated need, follow the protocol for poor milk supply or transfer. If the transfer estimate is higher than the estimated need, follow the protocol for oversupply. If the transfer estimate is roughly the same as the estimated need, schedule follow-up contact to ensure that the problem is resolving. Note, any one feeding does not necessarily indicate a typical milk intake. For this reason, it is helpful to observe several feedings over a period of time. Over a period of time to get a better estimate of average transfer. Hi. Hi. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and or ensure appropriate referrals. Expected resolution. When the baby is in a receptive feeding state and able to transfer adequate milk, this problem should resolve. Encourage parents to provide lots of snuggling and interaction with the baby to meet the baby's contact needs between feedings. What else to consider? Comprehensive pediatric evaluation. Teething, ear infections, and other issues can drive the baby to seek the breast for comfort without adequate milk transferring. It is thought that some babies, if not offered cuddles and attention between feedings, may demand frequent feeds to meet their need for comforting touch. We cannot say enough about the importance of cuddling and skin contact to calm, soothe, and nurture babies and their parents. Concern: I'm worried about my milk supply. Descriptor: concern about adequacy of milk supply. Often parents are concerned about producing an adequate amount of milk. Friends and family may support this concern. Among the factors that may increase this concern are the following: baby has not gained an adequate amount of weight. Baby falls asleep after just a few minutes of feeding. Baby seems unsatisfied after feedings. Breasts feel empty. Expressed milk volume is less than expected. Baby wants to feed more often than expected. The breasts are described as feeling soft and empty. Ask yourself, could this be the normal breast changes of the first month of feeding? Could these breast changes be consistent with long-term nursing, the change of milk production from fill and store milk to milk production on demand? Have the baby's weight gain and output been appropriate? Does the baby appear dehydrated, jaundiced, malnourished? What to do about it? If there are no indications of a milk supply and or intake problems, discuss normal breast changes. Observe a feeding and evaluate using the feeding observation checklist. If the history of the problem and the baby's weight gain indicate a possible milk supply or intake problem, take the following steps. Obtain a pre-feeding weight if possible. See protocol in Appendix E. Observe a feeding using the feeding observation checklist. Conduct a post-feeding weight check. Conduct a post-feeding weight check. Calculate milk transfer. Calculate the baby's approximate daily needs and divide that figure by the amount of reported feeds in 24 hours. How does the amount arrived at compare with the amount of milk transferred during this feeding? If the transfer estimate is much lower than the estimated need, follow the protocol for poor milk supply transfer. If the transfer estimate is higher than the estimated need, follow the protocol for oversupply. If the transfer estimate is roughly the same as the estimated need, schedule follow-up contact to ensure that the problem is resolving. Note, any one feeding does not necessarily indicate a typical milk intake. For this reason, it is helpful to observe several feedings over a period of time to get a better estimate of average transfer. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and ensure appropriate referrals. Expected resolution. When concern about milk supply is not confirmed by problems with the baby's growth, the family's fears may diminish with empathetic counseling. When potential milk supply or intake problems are confirmed by poor growth in the baby, resolution varies with the nature of the underlying problem. In rare cases, it may not be possible to produce a full milk supply. Frequent follow-up is indicated. What else to consider? Comprehensive pediatric evaluation. Teething, ear infections, and other issues may drive the baby to seek the breast for comfort. Maternal physical evaluation, including hormone levels. Physical problems such as retained placental fragments, thyroid and other hormone problems, polycystic ovarian syndrome, and history of breast surgery and trauma have been associated with inadequate milk production. In our opinion, it is common for parents to experience persistent concern about milk supply. Acknowledging, normalizing, and exploring this concern is indicated. This concern should be taken seriously regardless of the baby's growth. Concern: I'm worried about my milk supply. Descriptor: concern about adequacy of milk supply. Often parents are concerned about producing an adequate amount of milk. Friends and family may support this concern. Among the factors that may increase this concern are the following: baby has not gained an adequate amount of weight. Baby falls asleep after just a few minutes of feeding. Baby seems unsatisfied after feedings. Breasts feel empty. Expressed milk volume is less than expected. Baby who wants to feed more often than expected. You know what's frustrating about reading this is that you feel like you're reading the same thing over and over, and it is. It's literally repeating it, but it's just rewording it for these unique instances. So just beware if you're reading through this. It's the same, but it's not, and that could be really frustrating. So just pay attention. Unique identifier: a small quantity of milk is reported. So what makes these sections different, is that it's the unique identifier. So the last one was the breasts are described as feeling soft and empty, and the one before that was after breastfeeding, the baby is unsettled and fretful. So basically it starts with what are the descriptors about the concerns of milk supply. And they're all the same descriptors, but there's something that's unique about that specific instance, and these are the unique ones. So in this unique instance or unique identifier, it's a small quantity of milk of expressed milk is reported. Ask yourself, what has the experience with milk expression been? What methods are being used to collect her milk? Have the baby's weight gain and output been appropriate? Is this a new phenomenon? What to do about it? If there are no indications of milk supply and or intake problems, acknowledge this common experience. Explain that it is common to be able to express only a few droplets of milk initially before becoming accustomed to milk expression. If this is a change, gradual or sudden drop in milk expression volume, explore changes or additions to daily routines, e.g. taking new medications, nutritional supplements or herbs, decreased number of feedings or expressions. Changes to any pumping equipment, onset of menstruation, onset of new pregnancy, etc. Teach or reteach milk expression techniques. Encourage nipple stimulation and massage prior to expression, and the use of guided imagery and other tools that may enhance milk flow. If the breast pump is used, check the pump for missing parts or assembly problems. Ask the manufacturer how to check the pressure generated by the pump. Observe a pumping session and check for appropriate technique and good fit of the flange. If the method of expression is currently only a breast pump, encourage considering the addition of hand expression. Suggest consideration of expressing a suckled breast using one flange of the breast pump or hand expression while nursing the baby. This may increase yield. Or combining hand expression with pumping. Encourage tracking expression volume over time, expecting a gradual increase. If the history of the problem and the baby's weight gain indicate a possible milk supply or intake problem, undertake a feeding observation. Suggest other changes to feeding process indicated by the feeding observation. Schedule follow-up and ensure appropriate referrals. Expected resolution. Practice is the way to become more adept at milk expression. In cases where the adequacy of the milk supply is confirmed, milk expression can assist in stimulating milk production. Milk express may be used to supplement the baby if supplementation is prescribed. What else to consider? If milk cannot be expressed from the breast or colostrum is expressed beyond the first 4 days of life, a comprehensive maternal medical evaluation is indicated. Problems such as retained placental fragments and history of breast surgery have been associated with the phenomenon of not moving on to adequate production of milk as expected. In our opinion, it seems common to imagine that a full bottle of milk can be expressed on the very first attempt. This is a very rare experience. Rather, the body needs to be tricked into letting down to the hand or the pump. What pump is as adorable as the baby? It usually takes time and practice to become adept at expressing milk. Hand expression is a vastly underrated skill. It is expected that it should be universally taught during the hospital stay. It is not. I'll tell you my personal experience is that I was in Italy with my baby, my now teenager, and I had bought the breast pump, my breast pump, and when I went to plug in my breast pump, it blew a fuse and it broke the breast pump. So I had no choice but to hand express. And I expressed a lot, but it wasn't what I was expecting. And so I think that when we're teaching our families about the breast pump, we're talking about breast pump and breastfeeding, hand expression is a skill that needs to be shared in the hospital and postpartum. So try to add that to your postpartum visits as a new skill for your families. Concern. I'm worried about my milk supply. Descriptor. Concern about adequacy of milk supply. Often parents are concerned about producing an adequate amount of milk. Friends and family may support this concern. Among the factors that may increase this concern are the following. Baby has not gained an adequate amount of weight. Baby falls asleep after just a few minutes of feeding. Baby seems unsatisfied after feedings. Breasts feel empty. Expressed milk volume is less than expected. Baby wants to feed more often than expected. Unique identifier. The baby's feeding frequency is interrupted by the family as a sign of inadequate milk volume or poor milk quality. Ask yourself, could this be the normal baby behavior of the first month of breastfeeding? Could this be normal baby behavior consistent with long-term nursing, changed due to changes in baby distraction, playfulness, or sleep patterns? Have the baby's weight gain and output been appropriate? Does the baby appear dehydrated, jaundiced, or malnourished? What to do about it? If there are no indications of a milk supply and or intake problem, discuss normal baby behaviors appropriate for the age of the baby. Observe a feeding and evaluate using the feeding observation checklist. If the history of the problem and the baby's weight gain indicate a possible milk supply or intake problem, take the following steps. Obtain a pre-feeding weight if possible. Observe a feeding using the feeding observation checklist. Conduct a post-feeding weight check. Calculate. Sorry. This cat. No. You can't go here. I really need to read and get through this, okay? Stop. Conduct a post-feeding weight check. Calculate milk transfer. Calculate the baby's approximate daily needs and divide that figure by the number of reported feeds in 24 hours. How does the amount arrived at compare with the amount of milk transfer during this feeding? If the transfer estimate is much lower than the estimated need, follow the protocol for poor milk supply or transfer. If the transfer estimate is higher than the estimated need, follow the protocol for oversupply. If the transfer estimate is roughly the same as the estimated need, schedule follow-up contact to ensure that the problem is resolving. Note, assessing a single feeding in this way does not necessarily indicate a typical milk intake. For this reason, it is helpful to observe several feedings over a period of time to get a better estimate of average transfer. Suggest other changes to feeding process indicated by the feeding observation. Reteach feeding and satiety cues as needed. Schedule follow-up and ensure appropriate referrals. Expected resolution. When concern about milk supply is not confirmed by problems with the baby's growth, the family's fears may diminish and empathetic counseling and teaching. I just want to see how many times I'm going to read the same thing. Okay, when potential milk supply intake problems are confirmed by poor health, poor growth in the baby, resolution varies with the nature of the underlying problem. In rare cases, it may not be possible to produce a full milk supply. Frequent follow-up is indicated. What else to consider? Comprehensive pediatric evaluation, teething, ear infections, and other issues can drive the baby to seek the breast for comfort more frequently than previously. Maternal physical evaluation, including hormone levels. Physical problems such as retained placental fragments, thyroid and other hormone imbalances, polycystic ovarian syndrome, and history of breast surgery and trauma have been associated with inadequate milk production. In our opinion, it is common for parents to experience persistent concern about milk supply if they don't understand the easy digestibility of breast milk, responsive feeding, feeding cues, and satiety cues. Acknowledging, normalizing, and exploring this concern is indicated. This concern should be taken seriously regardless of the baby's growth. Concern: my baby won't take a. The wind is blowing the pages. Concern: my baby won't take a bottle or cup. Descriptor: baby refuses to drink from a bottle or cup. Unique identifier: baby refuses alternate feeding methods. Ask yourself, who has attempted to feed this baby? Parents, daycare provider, other family member? What has been offered to the baby? Expressed milk, formula, other beverages? Where has feeding been attempted in the presence or absence of the nursing parent? When has feeding been attempted? Explore cue, state of the baby, and so on. Why has alternate feeding been attempted, e.g. separation due to return to work, school, occasional relief feeding? How has fluid been offered? What devices have been used? Bottles, teats, cups, spoons? Watch out for cue state of the baby at time of attempted feeding. Parental response to cue state of the baby. Manner in which the baby is held for feeding. What to do about it. Interview about attempts that have been made to feed the baby with a bottle or cup. Ask the questions from the preceding Ask Yourself section. Observe an attempted feeding. Encourage bottle to cup or other method to be offered when the baby is in a quiet, alert stage and not exhibiting signs of overt hunger. Encourage that feeding be preceded by some gentle, pleasurable interaction with the individual who will feed the baby. Note, it is often easier for babies to accept an alternate feeding device from someone other than the nursing parent. Babies may be confused by the sensory cues they receive when in that parent's presence and may not be able to focus on learning a new way of feeding when in close proximity to that parent. What a word salad. Basically, babies will get confused if you're the mother feeding and you're trying to give them a bottle because they're not used to that. But it may be easier with somebody else. Some babies even refuse to accept an alternate feeding method when they can see, hear, smell, or otherwise sense the nursing parent's presence in the home. Encourage the person who is feeding the baby to begin by gently massaging around the baby's lips with clean fingers. The purpose of this action is to draw the baby's attention to the mouth in a pleasurable way. Once the baby shows some interest in the massage, e.g. turning head toward the stimulus, opening the mouth, the bottle or cup should be raised to the baby's lips. If using a bottle, try one with a large dome around the nipple, as this can be used to stimulate the wide open mouth position of the baby feeding at the breast. Hold the bottle in a position that is parallel to the floor so that the baby is not in a dependent position. If using a cup, use appropriate cup feeding techniques. Coach the parents to raise the cup just so that the fluid touches the baby's mouth rather than pouring fluid into the baby's mouth. Let the baby pace the feeding. The baby should be allowed to rest as needed during the feed and allowed to stop when ready. The baby's eyes may be closed during part or all of the feeding. Let me just pause and get a sip of coffee. Expected resolution. It may take time for the baby to learn to accept the new feeding method. Babies typically come to accept alternate feeding devices after some exposure to them. What else to consider? Consider other methods of supplementation. The baby who will not accept a bottle may be happy with cup feeding. Other babies prefer fluid from the spoon or sip type cup. If the alternate feeding device is being used to supplement the baby who is not receiving enough milk at the breast and is able to feed at the breast, consider at breast supplementation. Comprehensive pediatric evaluation is needed if refusal is strong or consistent. Rarely, a suck, swallow, or other intraoral problem has been discovered in these cases. It is never appropriate to support the common belief that babies will learn to feed in a different manner when they are hungry enough. Although those who espouse this belief do so in an attempt to reassure the parents, it may lead to the unfortunate practice of starving the baby out. Very hungry babies have less energy and patience for learning new feeding methods. Babies may also come to distrust those around them when caregivers are not responding to the baby's need for food, a primal need that should never be ignored. There are pros and cons to all alternate feeding devices. Be prepared to aid parents in choosing a method that protects milk production and suits their baby's abilities and their own skill and situation. Concern: my baby won't sleep through the night. Descriptor: baby sleep pattern does not match parental expectations. This is a big one. The whole baby sleeping through the night is not actually, that's not what we want. Unique identifier: parental expectations of baby's bedtime sleep pattern is not being met. Ask yourself, how old is the baby? How long has this problem existed? What does sleeping through the night mean to this family? How many hours is the baby sleeping in a stretch at night? During the day? When does the baby go down to sleep for the night? When does the baby awaken for feedings? Have the baby's weight gain and output been appropriate? Watch out for unreasonable expectations about baby's sleep. So this comes a lot from grandma, grandpa, family, cousins. They're like, is he sleeping through the night? Okay, he is. That's a good baby. He's not sleeping through the night. Oh, maybe you need to put a little cereal in the milk, or all these other things. And that's not the move. You really need to observe the baby and all these appropriate indicators for how and when they sleep, or why they sleep the way that they do. Sleeping through the night is not an indicator of a perfect baby. Watch out for unreasonable expectation about baby sleep. The longest stretch of sleep that can be expected in a breastfed baby after the newborn period is 5 to 6 hour stretch per 24 hours. If the baby sleeps for 5 to 6 hours during the day, he or she probably will not be able to repeat a sleep of that length at night and gain adequate weight. Again, my baby is so good, my baby sleeps all day, and then he's not sleeping through the night. Guess why? Because he slept. He slept the whole day. He slept for the length of time that he was, the stretch of time that he was supposed to sleep. And then we can't have that same expectation for the night. Some babies wake frequently at night when they do not have adequate access to human milk during the day. This can be due to parental distraction, e.g., many demands on time may mean that early feeding cues are not noticed. Babies who spend a lot of time in the car may be lulled to sleep more often during the day. Or baby distraction, e.g., around 4 to 6 months, many babies become distracted during the day by other activities such as creeping and crawling and feed less often. Either family or baby distraction can lead to more night feeding. What to do about it? Explore the baby's sleep pattern with the family. Compare the baby's daily sleep pattern with age-appropriate expectations. See preceding section. Identify whether there is a problem with the baby's growth or other indications that the baby may be feeding at night to make up for lost daytime feeding opportunities. If day-night imbalance problems are discovered, encourage the family to work on changing the daytime patterns first. For example, if the baby is sleeping 5 to 6 hours during the day, encourage the caregiver to observe the sleeping baby and pick baby up when light sleep stage, marked by rapid eye movement under the lids, is seen. The baby can be easily and gently offered a feeding while his or her eyes are still closed and in REM. Expected resolution. Feeding the baby more often during the daytime will lead to less awakening at night. What else to consider? Comprehensive pediatric evaluation. Babies who are in pain may awaken more often and seek food for comfort. Pain can result from teething, ear infection, and other problems. Actually, I want to highlight that. Feeding the baby more often during the daytime will lead to less awakening at night. So, if you want that 5 to 6 hour stretch at night, then feed more frequent feedings, which they should be doing anyway, the 10 to 12 feedings a day. Uh, Encourage more feeding and less on the time, like less on the 15 to 20 minutes every 2 hours and more on, am I feeding 10 to 12 times a day? Um, okay. In our opinion, a discrepancy between parental sleep expectations and reality is one of the most difficult problems for the sleep deprived family to solve. Encourage families to adopt a proximate sleep environment, meaning that the baby sleeps in close proximity to the parents in the same room in a safe sleep environment. Ideally, in the first few weeks, if possible, encourage adults to nap during the day when the baby sleeps. More information about safe sleep can be found in section 7. Concern: my baby won't stop crying. Descriptor: baby is inconsolable. Unique identifier: parents are unable to soothe their crying baby. Ask yourself, how long has this problem persisted or existed? What preceded the crying? What methods have been used to attempt to calm the baby? Watch out for: the truly inconsolable baby needs urgent medical evaluation. Baby's cue state: parental response to baby's cue state. Visible symptoms of pain or distress. What to do about it: encourage skin-to-skin contact to calm the baby. Calm the environment. Consider sound, light, motion, and so on. Suggest other comfort techniques as needed, such as massage, rocking, singing, and bathing. Encourage offering the breast when the baby demonstrates feeding cues. What else to consider? If these techniques do not calm the baby's crying or any of the pediatric warning signs are seen, the baby needs emergent care. The family of the baby who cries repeatedly needs support. Family members may need some time out opportunities to care for themselves. See also colic. In our opinion, crying babies deserve comfort. Crying does not exercise the lungs or serve any helpful purpose for the baby. That's a big one too. Like crying it out, it doesn't exercise the lungs, no. And in the young or ill baby, excessive crying can be detrimental to growth as it increases stress and burns calories. That's a unique one. More crying, the baby is more stressed, and they're burning calories that they need to really hold on to. I hope that my mic didn't get missed in that. Concern: my baby won't wake up enough to nurse well. Descriptor: baby acts sleepy and disinterested in breastfeeding. Unique identifier: sleepy baby. Ask yourself, how old is the baby? When did the problem begin? Have the baby's weight gain and output been appropriate? Do parents understand and respond to feeding cues? Watch out for: true inability to awaken needs emergent medical evaluation. Breathing problems in the baby require urgent medical evaluation. Inadequate urinations and or stooling in the baby. Calorically deprived babies seem sleepy. Require urgent medical evaluation. Diagnosed congenital anomalies and neurologic problems can result in arousal difficulties. What to do about it? Encourage the observation of the baby while sleeping and responsive feeding. The baby should be picked up and brought to the breast when signs of light sleep, REM sleep, are seen, e.g. eyes moving under the lids, small movements of the body, changes in facial expression, small sounds, and the hands, fist. Hold the baby skin to skin between feedings to improve motor and state organization. Explore the baby's sleep environment. When babies are very warmly dressed or wrapped, they may sleep longer. Swallow babies may not rouse themselves as easily when transitioning from deep to light sleep. Take a feeding history. Determine if an adequate number of effective feedings is occurring in a 24-hour time period, 10 to 12 feeds per 24 hours for a newborn. Ensure comprehensive pediatric evaluation if there is any indication of a recurring pattern of low frequency of feeding or difficulty rousing the baby from deep sleep. Expected resolution. As the baby gets older, he or she will learn to regulate sleep, wake, and feeding patterns. The family will become adept at reading and interpreting the baby's language. In the newborn, recovery from birth, as well as exposure to labor and delivery pain medication administered to the mother and or anesthesia given directly to the baby for painful procedures may result in transient changes to the normal sleep-wake cycle. What else to consider? Could the baby be marginally nourished, jaundice, or dealing with infection or other condition? Ensure comprehensive pediatric evaluation of weight gain problems, development, output, and sleep patterns. Explore daytime pattern in the baby's environment. Might there be too much environmental stimulation, such as sound or light, causing the baby to shut down? See also jaundice. In our opinion, a baby's ability to rouse easily from deep sleep can be life-saving in the event of apnea. Parents are justified in their concern about babies who have long periods of deep sleep. Concern: my baby has colic. Descriptor: uncomfortable baby with symptoms of colic. Colic was characterized by Wessel and colleagues in 1954 as a condition of infancy described by the classic rule of 3. Bouts of high-pitched crying lasting more than 3 hours a day for more than 3 days a week and for more than 3 weeks in a well-nourished, otherwise healthy baby. Colic typically starts after 2 weeks of age and resolves by 4 months. I'm going to highlight that about colic. Bouts of high-pitched crying lasting more than 3 hours a day for more than 3 days a week and more than 3 weeks in a well-nourished, otherwise healthy baby. It starts after 2 weeks of age and resolves by 4 months. So between 2 weeks and 4 months. That's interesting. I did not know that. Okay. Unique identifier: prolonged and specific crying in a breastfed baby. Ask yourself, what was the baby's age at onset? When did the problem begin? Who has diagnosed this problem as colic? The pediatric care provider? The family? Watch out for when the symptoms occur. What to do about it? Explore the history of the problem. Observe a feeding using the feeding observation checklist, Appendix B. Looking especially for any problems that may increase baby's gastric discomfort, e.g. baby crying before or during feeds may introduce extra air into the digestive system. A large milk supply, a fast rate of flow of milk, or suboptimal seal at the breast may increase the baby's gastric discomfort. Teach parents soothing methods, singing to the baby, rocking, walking, skin-to-skin comfort, baby massage, and so on. Encourage parents to take turns having time out if needed from the distraught child. Expected resolution. Colic symptoms typically begin after 2 weeks of age and resolve by 4 months. Changing the nursing parent's diet may alleviate colic in some cases. The major causes of colic are unexplained, but it is thought to be related to the maturation of the gastrointestinal and nervous systems. What else to consider? Specialized gastrointestinal evaluation. A trial of removing cow-based dairy foods, especially liquid cow's milk, from the parental diet may be conducted for 10 to 14 days to determine if colic symptoms decrease. If symptoms do not change, encourage resumption of the normal diet. See also crying. Let's see, 144. We have 20 pages left. We can do this. Let me take a break, get some water, coffee. And then I will continue. Whew. I'm just wanted to respond to someone. Okay. In our opinion, most babies have some gastric discomfort. This does not necessarily indicate colic. Some nursing parents will restrict their diet severely, often without positive effect on the baby's symptoms. This may be completely unnecessary, as only a portion of colic cases can be alleviated by dietary changes. If a dietary trial does not alleviate symptoms, encourage resumption of the normal diet and focus on helping the family learn healthy coping skills for responding to the baby's discomfort. Concern: my baby has jaundice. Descriptor: visible yellow coloration of the baby's skin and possibly the whites of the baby's eyes. Unique identifier: jaundice in the breastfed baby. Ask yourself, when was jaundice diagnosed? Who diagnosed it? What was the baby's age at onset? What was the gestational age of the baby at birth? Watch out for signs of dehydration, e.g. sunken fontanelles, decreased urination, brick dust urine, decreased stooling. What to do about it? Confer with a pediatric care provider about the feeding plan. Observe a feeding using the feeding observation checklist. Assess milk transfer using pre- and post-feeding weight checks. Suggest ways to improve milk supply if needed. Ensure comprehensive pediatric evaluation as needed. If any condition that might limit milk production is discovered, ensure that the pediatric clinician is apprised. Expected resolution: babies with jaundice may be somewhat lethargic. Milk expression and alternate massage during feedings may help to increase the milk supply and intake. Once jaundice resolves, the baby's ability to feed should normalize. What else to consider? Avoid use of a bottle or other feeding device with a firm teat. At breast supplementation is ideal in this situation. If the baby is supplemented away from the breast, consider supplementation via cup. See also sleepy baby. In our opinion, low levels of transient jaundice is in a full-term healthy baby, breastfed baby appears to be normal. However, any jaundice needs to be seriously considered because of the risk of kernicterus. High bilirubin levels may indicate that there were disturbances in early feeding and contact or the presence of an underlying medical condition such as an infection, hemolysis from blood type, and compatibility between mother and baby, or conditions such as G6PD, glucose 6-phosphate dehydrogenase deficiency. This is, yeah. It's not an equitable read. Due to the fear of kernicterus, jaundice must also be appropriately identified and treated. Follow-up checks are necessary since physiologic jaundice peaks on days 3 to 5. Human milk, fed frequently, is the ideal food for all babies, including those with jaundice. Concern: my baby has hypoglycemia. Descriptor: hypoglycemia. Hypoglycemia is a condition in which the amount of blood glucose sugar in the blood is lower than normal or desirable. Unique identifier: hypoglycemia in the breastfed baby. Ask yourself, is this baby at higher risk for hypoglycemia? AAP Committee on Fetus and Newborns 2011. I guess you're supposed to reference that. Less than 4,000 grams or greater than 4,000 grams or less than 2,500 grams at birth. Large gestational age, small for gestational age, or intrauterine growth restriction. Babies of diabetic mothers greater than, the other one was greater than greater than 4,000 grams or less than 2,500 grams. This other one is babies of diabetic mothers greater than 37 or less than 42 weeks gestation at birth. Suspected neonatal sepsis or maternal chorioamnionitis. APGAR score is less than 7 at 5 minutes. Newborns who required resuscitation, discordant twins, smaller, limited or no prenatal care, cold, stress or hypothermia, respiratory distress. Watch out for symptoms of hypoglycemia, including temperature instability, irritability or jitteriness, seizure activity, convulsions, exaggerated moral reflex, high-pitched or weak cry, respiratory distress, e.g., grunting or flaring, irregular respiration, apnea, cyanosis, hypotonia, bradycardia, poor feeding, and lethargy. AAP Committee on Fetus and Newborns, 2011. The baby with hypoglycemia can be very lethargic and sleepy at the breast and may not exhibit obvious feeding cues. What to do about it? Encourage as much skin-to-skin contact as possible. Take a feeding history. Discover how the baby has been doing with breastfeeding, whether he or she has received supplementary feedings, and if so, what has been given. Observe a feeding using the feeding observation checklist. Assess adequacy of milk transfer. Expected resolution. Hypoglycemia in the newborn is typically a short-term situation. The baby without underlying medical complications should be able to normalize blood sugar within a few hours of birth. Ongoing skin-to-skin contact and small amounts of colostrum obtained by licking and suckling at the breast typically assist the baby in normalizing the blood sugar within hours of birth. What else to consider? Comprehensive pediatric evaluation if problems with hypoglycemia are not resolved by skin contact and feeding, and or if signs of severe hypoglycemia are noted. In our opinion, skin-to-skin holding and feedings of colostrum are often underrated as first interventions for babies to prevent and treat hypoglycemia in an otherwise healthy baby. 15 minutes of skin-to-skin contact before retesting may increase the baby's blood glucose to an acceptable level. Concern: my baby has a birth defect. Descriptor: presence of a physiological anomaly in the breastfed baby. Presence of an anomaly does not mean that breastfeeding will be impossible. Among the physiological anomalies that may have an impact on breastfeeding are the following: cardiac heart defect, Down syndrome, craniofacial anomalies such as cleft lip, cleft palate, Pierre-Robin sequence, and so on. Galactosemia, phenylketonuria, phenylketonuria. Unique identifier: baby is diagnosed with a cardiac problem. Ask yourself, what is the extent of the impact of the baby's condition on breastfeeding? Watch the baby at the breast to assess the baby's ability to seek the breast, latch, and transfer milk. Watch out for babies with cardiac defects may fatigue easily at the breast, so they will need to be fed frequently. Observe for signs of cardiac problems such as circummoral cyanosis, blue, gray, or white coloration around the lips during feeding. What to do about it? Determine the feeding history, how the baby has been fed, how the baby is responding to feeding, and so on. Observe a feeding using the feeding observation tool. If possible, collect pre- and post-feeding weight checks to quantify milk transfer. Expected resolution. Cardiac defects have different degrees of impact on the ability to feed well in each baby affected. Many babies with cardiac problems can breastfeed well. However, they should be followed closely to ensure appropriate growth. What else to consider? For those nursing babies with diagnosed cardiac problems, milk expression after feeding is often needed to enhance milk removal and thus milk supply. If the baby does not transfer milk well during feedings, consider use of alternate massage and or at-breast supplementation with expressed breast milk. See also expression of breast milk, supplementary feeding devices. In our opinion, cardiac defects are among the most common birth defects, occurring in 1 in 10 births. Breastfeeding or feeding expressed breast milk. In the event that feeding at the breast is not possible, can be a wonderful contribution to the health of the baby dealing with a heart problem. Concern: my baby has a birth defect. Descriptor: presence of a physiologic anomaly in the breastfed baby. Presence of an anomaly does not mean that breastfeeding will be impossible. Among the physiological anomalies that may have an impact on breastfeeding are the following. It's the same thing as before. Cardiac heart defects, Down syndrome, craniofacial anomalies such as cleft lip, cleft palate, Pierre-Robin sequence, and so on. Galactosemia, phenylketonuria. Unique identifier. Baby is diagnosed with Down syndrome. Ask yourself, what is the extent of the impact of the baby's condition on breastfeeding? Watch the baby at the breast to assess the baby's ability to seek the breast, latch, and transfer milk. Babies with Down syndrome may fatigue easily at the breast, so they will need to be fed frequently. Babies with Down syndrome may have low muscle tone, as in figure 8.4, I will show that picture, that affect the baby's ability to create suction and draw milk from the breast, thus decreasing milk transfer, which can negatively affect milk supply. So here's an image here of the baby with Down syndrome or with low muscle tone. The baby with low muscle tone, hypotonic, may not have the ability to pull the head up when lifted by the arms. Observe for signs of cardiac problems such as circummoral cyanosis during feeding. Hold on. I just lost my space. What to do about it? Determine the feeding history, how the baby has been fed, how the baby is responding to feeding, and so on. Observe a feeding using the feeding observation tool. If possible, collect pre- and post-feeding weight checks to quantify milk transfer. Expected resolution. Down syndrome has a different degree of impact on the ability to feed well in each baby it affects. Many babies with a diagnosis of Down syndrome can breastfeed well. However, they should be following closely to ensure appropriate growth. Babies with Down syndrome become more proficient at breastfeeding with practice. What else to consider? For those nursing babies with Down syndrome, milk expression after feeding is often needed to enhance milk removal and thus milk supply. If the baby does not transfer milk well during feedings, consider use of alternate massage and or at-breast supplementation with expressed breast milk. See also expression of breast milk, supplementary feeding devices. In our opinion, it is well worth the clinician's time to support this family in breastfeeding. The many benefits of breastfeeding can be invaluable to this family and to this baby and this family, including reduced illness, increased IQ, enhanced bonding, and so on. Concern: my baby has a birth defect. Descriptor: presence of a physiologic anomaly in the breastfed baby. The presence of an anomaly does not mean that breastfeeding will be impossible. Among the physiologic anomalies that may have an impact on breastfeeding are the following: cardiac heart defects, Down syndrome, craniofacial anomalies such as cleft lip, cleft palate, Pierre-Robin sequence, and so on, galactosemia, phenylketonuria. Unique identifier. Baby has been diagnosed with a craniofacial anomaly. Ask yourself, what is the extent of the impact of the baby's condition on breastfeeding? Watch the baby at the breast to assess the baby's ability to make a seal on the breast. Keep the breast in the mouth, make and sustain a vacuum, and transfer milk. Watch out for problems coordinating breathing and feeding, signs of respiratory distress, for example, stridor, high-pitched noise when the baby inhales, circummoral cyanosis during feedings. What to do about it? Determine the feeding history, how the baby has been fed, how the baby is responding to feeding, and so on. Observe a feeding using the feeding observation tool. If possible, collect pre- and post-feeding weight checks to quantify milk transfer. With cleft lip, angling the breast so that the soft tissue fills the void in the lip may be a good solution. Alternately, the lip area may be held closed with fingers during the feeding. When dealing with a unilateral cleft palate, suggest angling the breast in the baby's mouth in such a way that the soft tissue of the breast fills the cleft area and the nipple extends into the intact side of the mouth. With Pierre-Robin sequence, upright feeding posture may assist the baby in achieving deep latch. Expected resolution. Babies with clefts and Pierre-Robin sequence have varying degrees of success in feeding at the breast. What else to consider? Many who nurse babies with these challenges will need to express milk after the feeding to maintain and increase their milk supply. If the baby does not transfer milk well during feedings, consider use of alternate massage and or at breast supplementation with express breast milk. Special feeding devices that rely only on positive pressure can create milk flow that have been used to feed babies who cannot transfer milk at the breast even when using an at-breast supplemental device. See also milk expression, supplementary feeding devices, alternate massage. In our opinion, in the event that a baby affected by one of these challenges and is unable to feed at the breast, ascertain if the parent wishes to express milk to be fed to the baby and provide support as needed. The baby will benefit from receiving human milk via any feeding method. In the event of a problem such as oral clefts, which will be surgically repaired, the baby may be able to breastfeed after the repair. Concern: my baby has a birth defect. Descriptor: presence of a physiological anomaly in the breastfed baby. Presence of an anomaly does not mean that breastfeeding will be impossible. Among the physiologic anomalies that may have an impact on breastfeeding are the following: cardiac heart defects, Down syndrome, craniofacial anomalies such as cleft lip, cleft palate, Pierre-Robin sequence, and so on. Galactosemia, the inability of the body to use simple sugar galactose, causing the accumulation of galactose L-phosphate in the body, which results in damage to the liver, central nervous system, and other body systems with potentially permanent, even fatal outcomes. This word again, phenylketonuria. Unique identifier. Baby has been diagnosed with galactosemia. Ask yourself, has the baby been screened for galactosemia? Is the baby showing any signs of galactosemia? Is prior to parents being notified about the results of a screening test? Is there a family history of galactosemia? Watch out for jaundice, vomiting, poor feeding, poor weight gain, irritability, lethargy, convulsions, and opacity in the lenses of the eyes, as these are all signs of galactosemia. What to do about it? Determine which form of galactosemia has been diagnosed, classic or Duarte. Classic galactosemia is the sole pediatric contraindication to breastfeeding. Babies with Duarte galactosemia may be able to breastfeed. Expected resolution. Breastfeeding is not recommended, except in individual cases of babies with Duarte galactosemia. Individuals with classic galactosemia must avoid all foods containing galactose, which occurs naturally in all mammalian milks, including human milk, as well as cow's milk-based formula, including those with reduced lactose. Consuming galactose will cause irreversible organ damage in the individual with classic galactosemia. A special formula is indicated. What else to consider? Support the family in decreasing milk production. See also weaning. In our opinion, these conditions are extremely rare. Classic galactosemia is thought to occur in 1 in 60,000 births. Duarte galactosemia appears to be more common in many populations. When counseling the family of a baby with classic galactosemia, allow space for the expression of feelings about loss of the breastfeeding opportunity. Concern: my baby has a birth defect. Descriptor: presence of physiologic anomaly in the breastfed baby. Presence of an anomaly does not mean that breastfeeding will be impossible. Among the physiologic anomalies that may have an impact on breastfeeding are the following: cardiac defects, Down syndrome, craniofacial anomalies such as cleft lip, cleft palate, Pierre-Robin sequence, and so on, galactosemia, and PKU. So I don't have to say that over again. Phenylketonuria, PKU. Baby has been diagnosed with PKU. Ask yourself, has the baby been screened for PKU? Newborns do not have, watch out for it. Newborns do not have symptoms of PKU. Symptoms occurring in the first months may include eczema, jerking movements of arms and legs, rocking, tremors, seizures, hyperactivity, microcephaly, vomiting, and a musty odor in the child's breath, skin, or urine caused by too much phen- phenylalanine, phenylalanine, phenylalanine in the body. What to do about it? Discuss the feeding plan with the pediatric care provider and the family. Typically, babies with this disorder can be partially breastfed and are also fed a formula that has been manufactured to not have phenylalanine, an amino acid that individuals with this disorder cannot metabolize safely. However, the volume of human milk consumed may have to be carefully monitored to ensure that levels of phenylalanine consumed are within safe limits. The baby will need some small amount of phenylalanine in the diet, which could come via breastfeeding. Expected resolution. The outcome for babies with PKU is good, provided that levels of phenylalanine consumed can be kept low. If the baby's diet is not followed carefully, irreversible brain damage may result. What else to consider? A team approach is best. The team should include, at a minimum, the lactation care provider, the pediatric care provider, and the dietitian to monitor the baby's progress. See also weaning. We're almost there, almost there. In our opinion, PKU is an uncommon disorder occurring in 1 in every 15,000 births in the United States. Concern: my baby has a birth injury. Descriptor: presence of a birth injury in the breastfed baby. Presence of a birth injury does not mean that breastfeeding will be impossible. Unique identifier: otherwise intact baby who was injured during the birthing process. Among the birth injuries that may have an impact on breastfeeding are the following: cephalomatoma or caput succedaneum. Cephalomatoma is a lump on the skull caused by bleeding beneath the bones of the skull. The lump arises within hours of birth. Caput succedaneum is a swelling of the soft tissues of the baby's scalp that develops as the baby travels through the birth canal. This may occur when vacuum extraction is used to assist in birth. Ask yourself, does the baby cry or seem unable to feed when held in certain positions? Does holding or supporting the baby differently change the baby's ability to breastfeed? How is the baby's head being supported? With this type of birth injury, there should be as little pressure on the head as possible. Watch out for people labeling the baby as hard to please or fussy, the family feeding inadequate, jaundice arising from resolving cephalohematoma. The baby's body reabsorbs the blood, increasing the amount of bilirubin in circulation. What to do about it? Investigate what the family has been told about the condition, determining the feeding history, how the baby has been fed, how the baby is responding to feeding, and so on. Observe a feeding using the feeding observation tool, Appendix B. If the baby is uncomfortable, try different feeding positions to attempt to take pressure off the injured area. Expected resolution. Often these conditions heal with time. However, physical therapy and other developmental interventions may be needed. Babies with brachial plexus injuries often have problems starting solid foods as well. What else to consider? Comprehensive pediatric evaluation and occupational and or physical therapy for the baby. A swallow study. See also expression of breast milk. In our opinion, it is not surprising that babies with these conditions may not enjoy feeding. They probably have severe discomfort and pain. Pain relief may be prescribed for the baby who has noticeable discomfort. Five more pages. Concern: my baby has a birth injury. Descriptor: presence of a birth injury in the breastfed baby. Presence of a birth injury does not mean that breastfeeding will be impossible. Unique identifier. Among the birth injuries that may have impact, let me just see something. Among the birth injuries that may have an impact on breastfeeding are the following: fractured clavicle, brachial plexus injury, and so on. Ask yourself, does the baby cry or seem unable to feed when held in certain positions? Does holding or supporting the baby differently change the baby's ability to breastfeed? People labeling the baby as spoiled or hard to please? The family feeding inadequate? Defining the situation as a breastfeeding problem and not seeking a medical evaluation? Aspiration pneumonia. What to do about it? Investigate what the family has been told about the condition. Determine the feeding history, how the baby has been fed, how the baby is responding to feeding, and so on. Observe a feeding using the feeding observation tool. If the baby is uncomfortable, try different positions to attempt to take pressure off the injured area. Babies with these conditions may feed best when they have less weight on the affected part of the body. This may require the use of pillows or other props to achieve comfort for the nurser. A feeding study will determine if the baby is aspirating milk. Milk aspiration can lead to chemical pneumonia, which can be life-threatening. Expected resolution. Often these conditions heal with time. However, physical therapy and other developmental interventions may be needed. Babies with brachial plexus injuries often have problems starting solid foods as well. What else to consider? Comprehensive pediatric evaluation and occupational and/or physical therapy for the baby. Swallow study. See also expression of breast milk. In our opinion, babies with these injuries are often seen as problem breastfeeders and are changed to bottle feeding. In this event, use expressed breast milk preferentially in the bottle. Feeding problems may reemerge when solid foods are introduced and the baby chokes and gags. Concern: my baby was born early. Descriptor: prematurity in the breastfed baby. Premature babies can have success with breastfeeding, but they may have a slow start. Unique identifier: baby was born before 37 weeks of pregnancy gestation. Extremely preterm is less than 28 weeks. Very preterm, 28 to 32 weeks. Moderate to late preterm, 32 to 37 weeks. Early term, 37 weeks through 38 and 6 and 7 weeks. 38, 6, 7 weeks? Who measures like that? Full term, 39 weeks through 40 weeks. Late term, 41 and 0 and 7th weeks through 41 and 6 and 7 weeks. Post term, 42 and 0 and 7 weeks and beyond. On average, newborns usually weigh about 8 pounds. Babies who are born weighing less than 5 pounds, 8 ounces are considered low birth weight. Low birth weight babies may be healthy but small or have serious health problems that mean spending time in the NICU even if full term. Low birth weight babies may have a difficult time staying warm and feeding at the breast right away, even if a low birth weight baby is full term. Strategies used to support breastfeeding for the premature baby may be helpful. Ask yourself, how is the milk supply being supported? What is required regarding collection and storage of milk? What are the possibilities for skin-to-skin holding and practice breastfeedings? Watch out for parents perceiving the baby as very fragile, their family feeding inadequate, difficulty regulating the baby's heart rate, oxygenation, temperature, and breathing when breastfeeding, concerns about adequacy of milk supply. What to do about it? Investigate what the family knows about prematurity and the baby's ability to feed. Determine if the baby has been stable enough to have skin-to-skin contact with parents. Determine the feeding history, how the baby has been fed, how the baby is responding to feeding, if the baby is receiving human milk, if feeding is fortified, and so on. Explore the milk expression plan and fine-tune as needed. For optimal results, milk expression should begin within 1 hour of birth and continue a minimum of 8 times in 24 hours to sustain adequate milk production when the baby is not yet ready to feed at the breast. Hand expression in the early days is preferable to expression with a pump. When the baby is deemed ready for feeding at the breast, work with parents to establish reasonable expectations for the first feedings. For example, the baby will lick or nuzzle at the breast rather than latching on and suckling vigorously. There is no specific age at which babies are ready for the breast. Coordination of the suck, swallow, breathe, and gag reflexes is important for safe oral feeding. The baby's inability to regulate cardiorespiratory stability should be the indicator that determines readiness for feeding at the breast. Observe a feeding using the feeding observation tool. Observe a feeding using the feeding observation tool. A special breastfeeding assessment tool is available for use with preterm babies. Establish appropriate follow-up plans. Expected resolution. Preterm babies grow in their feeding abilities with practice and a number of opportunities to try. The more time spent with the baby in skin-to-skin contact and having practice breastfeedings, the faster the baby will become adept at feeding. What else to consider? Pediatric evaluation and referral to occupational and/or physical therapy for the baby. See also expression of breast milk, collection and storage of breast milk, breastfeeding positions, protocol for building the milk supply. In our opinion, preterm babies benefit greatly from receiving breast milk. Human milk is protective against necrotizing enterocolitis, a serious disorder common in preterm babies. Breastfeeding also allows the parent to observe the baby's innate abilities. Along with all preterm babies, late preterm infants, LPTI, require special attention. While these babies are more likely to appear to have a capability similar to full-term babies and to be cared for in the maternity unit rather than the NICU, they are often sleepier, show fewer feeding cues, and have a lower energy reserve. These factors may decrease the milk production potential, downregulate whatever milk production there is, and lead to low weight gain or even weight loss for the LPTI. We encourage lactation care providers to observe these babies closely to determine if they are feeding adequately and effectively. And that is the end of section 8. We did it. We listened. We read. We're done. Thanks for listening.